Assalamualaikum and a very good morning to Dr. Wanajiba and my friends. I am Nur Atira, and along with my friend Shahira, we will present to all of you about otitis media and cleft palate. I will present about otitis media and Shahira will proceed with cleft palate. Otitis media. So, what is otitis media? Derived from the word ot, which means ear, itis inflammation, and media relating to the middle, it is basically an inflammatory condition of the middle ear, characterized by accumulation of fluid in the middle ear and bulging or perforation of the eardrum. It is very common in children. In fact, it is the most frequent diagnosis made by pediatricians of children under 15 years of age, as nearly 50% of children will have at least one episode of otitis media in their first year of life. Otitis media can be categorized into few types, which are acute otitis media with effusion, and chronic suppurative otitis media. Firstly is acute otitis media. Acute otitis media is a rapid onset of infection occurring within 48 to 72 hours prior to a medical appointment, and it will resolve quickly. The etiology of acute otitis media may be from viral or bacterial agents, for example, Staphylococcus aureus or Streptococcus pneumoniae. This usually happens following an upper respiratory tract infection. The usual initial symptoms is otalgia, which is ear pain. In children, especially infants, they will be cranky by crying excessively, causing them difficulty to sleep at night. Some may also display behaviors like tugging of the ear, which shows their discomfort due to the ear pain. Other systemic symptoms may also be presented. Next is otitis media with effusion, or sometimes we call them serous otitis media. It is a condition where there is non-infected thin serous effusion in the middle ear. It is caused by an obstruction of the eustachian tube, which can be without infection, or it can also occur following an episode of incomplete resolution of acute otitis media. Since there is no infection, therefore it is common to be asymptomatic. Some may experience oral fullness, but this can only be reported by older children or adults. Usually, in cases of otitis media with effusion, the parents will notice reduced hearing in their children as they may be less or non-responsive to sounds. Another type of otitis media is chronic suppurative otitis media, or in short CSOM. CSOM is defined by a persistent, happening for at least 6 weeks, chronically draining suppuration through tympanic membrane perforation. It usually occurs as a complication to recurrent acute otitis media, but can also result from eustachian tube obstruction, mechanical trauma, thermal or chemical burns, blast injuries, or iatrogenic causes. Having persistent CSOM should alert a risk for cholesteatoma, as it can result in destructive changes of the middle ear, such as necrosis or oral polyps. The symptoms include painless otorrhea since the tympanic membrane is already perforated, and also with conductive hearing loss. This is the summary for all three types of otitis media. What to note in here is that otalgia, which is ear pain, only occurs in acute otitis media, and otorrhea, which is ear discharge, only in chronic suppurative otitis media. As for the tympanic membrane, both acute otitis media and otitis media with effusion has intact tympanic membrane, while it is not in chronic suppurative otitis media. Pathophysiology of otitis media. So, how did otitis media occurs? Basically, the main cause of otitis media is eustachian tube dysfunction. Eustachian tube is an anatomical structure which connects the middle ear and the nasopharynx. As we know, eustachian tube functions in ventilation and drainage of the middle ear fluid. Thus, when eustachian tube dysfunction occurs, there will be no mechanism that can allow the air and the fluid in the middle ear to escape, causing otitis media. Children are more prone to develop otitis media as their eustachian tube is still structurally and functionally immature, where their eustachian tube is shorter and more horizontal. This is the pathophysiology in which how the different types of otitis media occur. Firstly, It can start from an upper respiratory tract infection, which is an acute infection that involves the nose, the sinuses, the pharynx, or the larynx. This eventually causes swelling or inflammation of the eustachian tube. So when the eustachian tube swells, it is not able to function. In other words, the opening and closing mechanism cannot function accordingly. This condition is known as the eustachian tube dysfunction, which in turn will cause the negative pressure to build up in the middle ear as the air are trapped inside and cannot escape into the nasopharynx. Following that, the mucosal lining of the middle ear will continuously produce fluid and without any drainage, which will lead to accumulation of middle ear secretions. And in this environment, secondary bacterial or viral infection can occur, for example, from the Staphylococcus aureus or Streptococcus pneumonia. They will infect the middle ear and cause the acute otitis media. So, if the inflammation of the middle ear settles, there is usually resolution of the symptoms, particularly otalgia, which is ear pain. However, there are often residual fluid from previous acute otitis media, and this is called otitis media with effusion. So, apart from being a complication of acute otitis media with effusion can also occur from the eustachian tube dysfunction alone. Generally, it follows the same mechanism, but without a prior infection from here. And then next is chronic suppurative otitis media. Firstly, it can occur as a result of recurrent acute otitis media. And secondly, from the eustachian tube dysfunction alone. So, as the fluids keep accumulating in the middle ear, it will cause the pressure to increase and pushes the tympanic membrane outward. At one point, the tympanic membrane cannot hold in the pressure anymore, so it will perforate. This condition is termed as suppurative otitis media, characterized by ear discharge or in other words, otorrhea. Suppurative otitis media can become chronic and are thus named chronic suppurative otitis media. Otitis media has their distinct audiological features that can differentiate them from other causes of hearing loss. Most diagnoses of otitis media are made based on the initial otoscopy, which shows differences of tympanic membrane presentations based on their types. In acute otitis media, the tympanic membrane is seen as red with hypervascularity but still intact tympanic membrane. In otitis media with effusion, the tympanic membrane will show their bubbly or cloudy appearance, and oftentimes a meniscus that shows the middle ear fluid level can also be seen. Since otitis media with effusion does not come with otalgia, the blood vessels are not as apparent as in acute otitis media. In chronic suppurative otitis media, the tympanic membrane is perforated with suppurative discharge as seen in their moist-like appearance. One of the main tests for middle ear condition is of course the tympanometry. As seen from this diagram, various stages of otitis media will be shown on the series of tympanograms. From normal, which is type A, it will slowly changes into type C that marks eustachian tube dysfunction, and finally type B, which shows reduced compliance of the eardrum as a result of the middle ear pathology. To be noted that tympanometry cannot be performed on chronic suppurative otitis media or any discharging ear. Besides from tympanometry, otoacoustic emission can also be performed and in this case will be absent. This is due to the click stimuli being attenuated by the middle ear fluid, and the OAE from the cochlea can also be blocked. If acoustic reflex testing is performed, it will show a probe effect and even ear effect if the hearing loss is severe enough. For example, when the BC threshold is for example 0 dBHL, but then the AC threshold is for example 25 dBHL, this will cause probe effect. But if it drops down to maybe another 35 dBHL, that brought an airborne gap of more than 30 dBHL, ear effect may be presented. Last but not least, Since otitis media happens in the middle ear, it will show a purely conductive hearing loss if no sensorineural element is involved. As for the management, different types of otitis media requires different approaches. For acute otitis media, analgesics, which is painkillers, should be provided as it generally causes otalgia and discomfort, and weight-based doses are used for children. Although most cases resolve spontaneously, antibiotics will still be given when it is necessary to relieve the infection, for example using amoxicillin. In otitis media with effusion, for most patients, a watchful waiting is all that is required. However, occasionally Valsalva maneuver can also be performed for temporary ventilation and drainage. Next, if the otitis media with effusion happen to involve allergies, then antihistamines and corticosteroids will be prescribed. Still, if there is no improvement for 1 to 3 months, only then myringotomy with grommet will be performed. Myringotomy is a surgical procedure that makes an incision at the tympanic membrane in order to relieve the pressure or drain the fluid into the ear canal. Grommet, on the other hand, is a small tube that is inserted at the tympanic membrane to allow for ventilation and prevent fluid accumulation. Last but not least, chronic suppurative otitis media, which is often treated with tympanoplasty, as it involves perforation of the tympanic membrane. If there is any granulation tissue or cholesteatoma involved, it must be surgically removed. Topical antibiotic drops are also prescribed, for example ciprofloxacin.
Next, I'm going to talk about cleft palate. Palate here refers to the structure at the roof of your mouth, and cleft refers to a separation or a gap between two structures. Meanwhile, cleft palate means an opening or a split in the roof of the mouth. And as it can be seen from this picture here, it can occur with or without cleft lip, which is also an opening or split, but instead at the roof of your mouth is at the skin of your upper lips. To understand the formation of cleft palate, you need to know the normal palate development. So in human, palate are formed by two structures, primary and secondary palate. Primary palate are formed by intermedullary segment, while the secondary palate are formed by two shaft-like outgrowth that we call palatine shafts. So in the 7th week, palatine shaft, from the more diagonal position, it will ascend to a more horizontal position above the tongue, like right here, and it will fuse anteriorly with the primary palate. And then you see the big structure up here, which we call nasoseptums. It will scroll down and fuse with the palatine shaft to form the palate right here. Now, what is the cause of cleft palate? The embryology of cleft palate is the failure of the palate itself to meet and fuse with each other. Now, I can give you a very example from the picture on the left of the slide. So you see the first picture shown a baby with a cleft palate, which means the palatine shaft itself, both of it may impartial or fail to fuse with itself, while cleft palate, either with unilateral or with bilateral cleft lips, means, of course, first, the palatine shaft itself cannot fuse with each other, but also the secondary palate cannot fuse with the primary palate anteriorly, so it causes the cleft lip. How cleft palate affect hearing? To understand its effect on hearing loss, we need to understand the function of eustachian tube. Eustachian tube is a structure in the middle ear that connects middle ear cavity and nasopharynx. So why is it important? It is because the function of it. First, it acts as pressure stabilizer between the middle ear cavity and the nasopharynx. Second thing, it is to facilitate any secretion drainage from the middle ear. So typically, eustachian tube are closed at rest. But in order for it to do its function to act as pressure stabilizer to facilitate any secretion drainage, it needs to be opened. So the main muscle that helps with the opening of the eustachian tube is tensor velli palatini. Now these muscles, they contracted when we are swallowing food or sometimes during a later speech. Next, I'm going to show you the diagram of first the normal palate. As you can see here, the aponeurosis of the tensor velli palatini muscles, they hook around the humulus and insert itself along the posterior edges of the hard palate, giving it a very strong anchorage and a very strong force to be able to open the eustachian tube. Now look at the diagram of the cleft palate patients, we can see that instead of inserting itself along the posterior border of hard palates, it actually inserts itself along the bony edges of the bony cleft. Thus, it lacks that anchorage needed to effectively open eustachian tube, resulting in eustachian tube dysfunction because of functional obstructions. Again, the question is how does cleft palate affect hearing? So the first thing we know is the eustachian tube dysfunction because of the functional obstruction. This is caused by the insertion of the tensor velli palatini muscle itself that helps to open the eustachian tube. The insertion is improper because of the structure of the cleft palate. Now, in the middle ear, there is a constant gaseous absorption by the mucosal cell. But when the eustachian tube become dysfunctions, the gases that are being absorbed, they cannot be replaced. When it cannot be replaced, there will be a negative pressure build up, and this will result in the tympanic membrane become retracted into the tympanic cavity. At a certain point of the negative pressure becomes more and more, it will trigger the mucous membranes into secretion of fluid into the middle ear space. Now this fluid will become accumulated and it will resulting in otitis media with effusion. And as my friend earlier said, this otitis media with effusion, or as we can call it OME, they will cause conductive hearing loss. Now in children especially, hearing is very important because they help them to develop and acquire their speech and language. So when there is a hearing loss, inevitably there will be a speech and language that will delay because they lack a consistent auditory stimuli to help them recover, to help them build that speech and language. They may also have problems in auditory processing because the auditory pathway maturation are being delayed as their auditory pathway do not have enough stimulation to be matured. Next, we will go to the audiologic features. First, we want to look at otoscopic examination. In OME, tympanic membranes will look dull. As you can see here, it looks dull, translucent with diminished mobility. And second, you can see it because of the negative pressure pushed into the tympanic cavity, you will see the prominence of lateral process here. The second test that can be used is by using tympanometry. So there will be a type B tympanogram that will be shown during an episode of otitis media with effusion, which suggestive of the presence of middle ear fluid. The second type of tympanogram is type C tympanogram, which is most likely shown during early stage. And as you can see here, the one that have peak but more likely to the negative pressure is a type C tympanogram, and the ones that almost flat is a type B tympanogram. So the third test we use is audiometry. And now this audiometry test is quite tricky because we need to adjust it according to the patient's cognitive age. So for infants that are younger than 6 months, we usually undergo behavioral observation audiometry, BOA, while children that age 6 months to 2.5 years, we usually undergo visual reinforcement audiometry, VRA. The children that are older than 2.5 years, they will undergo play audiometry. And older children are evaluated using standard testing with audiometry, but with hand raising. So either it's shown or not in audiometry usually can produce mild to moderate conductive hearing loss. Next, we will go to the management. So infants with cleft palate, they are screened since birth for hearing impairments, and they are being taken care under multidisciplinary teams, including pediatrician, ENT surgeons, cosmetic doctors, speech pathologists, and audiologists. So as we know, the children with cleft palate, they come hand in hand with middle ear pathology because they have higher prevalence to have middle ear pathology that will resulting on conductive hearing loss, and this may delay their speech and language development and the maturation of auditory pathway. Thus, frequent visits to ENT doctor and audiologist for hearing assessment is a must for us to always monitor the hearing. So what happened during hearing assessment? During hearing assessment, if we see absence or no signs of any audiological features that we mentioned earlier, it means that the children pass the assessments. But if there is a audiological feature of ME, for example, retracted tympanic membranes, there is a type B tympanogram, or the audiometry showing mild to moderate conductive hearing loss, it means that they failed the assessment. So as audiologists, we refer to ENT doctor. So what ENT doctor will do, they will arrange a follow-up 3 months later because we want to see what happens in these 3 months. If it resolved by itself, then it's fine, it's okay. But however, if the OME still presents after 3 months, ENT needs to consider surgical intervention, which is myringotomy with ventilation tube placement. Myringotomy is an invasive procedure where the antidote will have incisive at the tympanic membranes for purpose of drainage, and ventilation tube placement are also for drainage for this episode of OME and the upcoming episode of OME. So because the ventilation ears, they can stay in the tympanic membrane of individual for about 8 to 12 months until the tympanic membranes heal itself. But what happens if the OME happens repeatedly? So if OME happens repeatedly to a patient, then we need to consider to fit hearing aids to the patient. In a study that I've read, it shows that repeated ventilation tube placement, it may cause harm to the hearings of the children in the long run. So I think it's a better thing to fit hearing aids to ensure better speech and language development. That's all from us. Thank you.